So yes, as you said, today I'm gonna present a little bit of a review of the characteristics of NF2 just to provide some background. Then I'm going to talk about data from a natural history study conducted at the NIH with Dr. Chino Boyna in the surgical neurology branch. I have no disclosures. Just starting with a little bit of history, NF2 was initially described in 1822 by Wishart. Up in the early 1900s, up until the genes were linked to chromosomes 17 and 22, there was a lot of mislabeling of both NF1 and F2, which created a bit of confusion within the literature. But in 1987, the NIH came up with a consensus on the criteria for NF1 and NF2 that helped to consolidate the research efforts. And the most current criteria were set in 2017. The diagnosis is based on fulfillment of any of the criteria listed here, the most pathognomonic finding being the bilateral vestibular schwannomas. But diagnosis can be made based on the presence of other associated tumors or a combination of tumors and family history or genetic testing. Although these more modern criteria do better describe the variety of phenotypes seen in NF2, there are still some limitations that are the subject of a little bit of critique, including the inclusion of gliomas within the criteria, as well as neurofibromas, ironically enough, since those are not usually seen in NF2 or more characteristic of NF1. There's also significant overlap with NF2 and schwannomatosis, which has different causal mutations. So often the recommendation is to consider both diagnoses and do genetic testing for both in patients where the picture is a little unclear. NF2 is rare. It is less common than NF1. It is autosomal dominant in inheritance and is due to that it's de novo in about 50%. Up to 20 to 30% of patients with no family history will have mosaic disease, which can lead to difficulties in determination of genotype. It does most often present in young adulthood in 20s and 30s, usually due to symptoms related to vestibular schwannomas, such as unilateral hearing loss, tinnitus, dizziness, etc. When children present, they less often present with symptoms related to vestibular schwannomas. They more often present with other tumors. And any patient under 18 with even an isolated meningioma will have a 20% chance of going on to develop NF2. For schwannoma, it's about 10%. And then after the age of 20, the risk of developing NF2 later drops dramatically. And then after 30 with a single meningioma or schwannoma, it's fairly unlikely. So vestibular schwannomas are seen in 90 to 95% of NF2 patients. Unlike in sporadic cases, they can arise from any part of the eighth nerve complex. They're less consistent in arising from the superior vestibular nerve. Often multiple tumors coalesce into a large multilobulated tumor, which is shown in the figure on the right and is kind of demonstrated by one of the patients in our cohort with these very multilobulated tumors. The rate of hearing loss varies and is independent of tumor growth size and rate. You can see on this graph here, which is kind of Kaplan-Meier curve of hearing over time in NF2 patients with stable untreated tumors. The hearing loss rate does increase with tumor size, but tumors can cause hearing loss even at a very small size. They've found that elevated protein within the labyrinth, which can be seen on high resolution FLAIR, does correlate with hearing loss, even outside of size. And so cochlear aperture obstruction with end organ deterioration due to accumulation of protein is thought to be the main mechanism driving hearing loss in NF2 patients. So hearing preservation is a major goal in treating NF2 patients for you want to preserve hearing as long as possible. Of course, patients who are treated conservatively tend to have the best hearing outcomes because these patients tend to have less aggressive tumors and present with less symptoms. But with surgery, hearing preservation is more likely to be possible in patients who have baseline better hearing, as is the case with sporadic cases. But overall, the rates of preservation of hearing and facial nerve function after surgery are worse than sporadic cases, unfortunately. One promising treatment that I'm not going to go into much detail about, but I'd like to touch on is with Avastin. Avastin can prolong hearing preservation and sometimes even improve hearing in NF2 patients, more often in patients with rapidly growing tumors, although the effect of Avastin is not completely understood. Right now, it's thought to be due to the effect on vessel permeability. That's causing restoration of the protein homeostasis within the inner ear, improving the protein accumulation within the cochlea, because tumor shrinkage on MRI doesn't exactly correlate to hearing response in these patients. The other hallmark feature of NF2 is multiple meningiomas. Meningiomas are most often intracranial, but are frequently seen within the spinal canal as well. They do unfortunately carry a significantly worse prognosis. Patients with intracranial meningiomas who have NF2 have a 2.5 times increased relative risk of mortality. The overall characteristics of these meningiomas are similar to the general population in terms of like most common locations, etc., but they do have a little bit higher tendency to be higher grade on histology. Intramedullary spinal cord tumors are also common. They're frequently seen on imaging, but rarely symptomatic. About 75% of these tumors will be ependymomas on histology if they are resected, and WHO grade 2. Most of these can often be observed as long as they remain asymptomatic, even if there is some change on imaging. And the many patients can go years without intervention for these lesions. NF2 patients can also suffer from other pathology, the most significant being ocular lesions. Many patients have cataracts, which are less often symptomatic. And then retinal hamartomas are also fairly common, which are a bit more symptomatic in their effect on visual acuity. Skin plaques and skin macules are seen less often than in NF1, but they are a feature of the disease. And then subcutaneous tumors can be treated if they are symptomatic, but unlike in NF1, there's not much of a concern for malignant transformation into a malignant peripheral nerve sheath tumor, so often these can be observed if they're not symptomatic. And then peripheral neuropathy is also seen in higher rates than in the general population. It's not at this time fully understood, but is a area of research going forward. So prognosis of patients with NF2 is highly variable. Disease severity does tend to be similar within families, which suggests that the mutation type has some weight onto prognosis. Most patients will eventually lose hearing and ambulation. And negative prognostic indicators include earlier age at diagnosis, presence of intracranial meningiomas, as I mentioned, and non-mosaic disease. The genetics of NF2 are the disease is caused by a mutation in Merlin, which is a tumor suppressor gene located on chromosome 22. I included this because we talked about it in conference recently. The name Merlin comes from the type of the protein family that it belongs to, not the King Arthur myth. It is a cytoskeletal protein involved in contact inhibition of cell proliferation and maintenance of membrane receptor signaling. Most often, disease-causing mutations are single base pair transitions, with nonsense being the most common, then frame shift and splice site and missense mutations. In general, nonsense and frameshift mutations have been associated with more severe disease, which is understood by the nonsense mutations and frameshift causing a truncation of the mRNA product, whereas missense mutations produce a different protein of a similar length that it's often just less functional or even non-functional, but not completely truncated. Splice site mutations have a more variable effect on the mRNA and on disease severity. But for our analysis, we grouped together truncating mutations, including nonsense and frameshift mutations, and then splice site mutations that had been demonstrated to cause truncation of the mRNA product, with the non-truncating mutations including copy number variants and missense mutations, which are significantly less common. So moving on to our study details, we had 169 patients who were enrolled based on clinical diagnosis. Patients were followed for 5 years with yearly assessments that included MRI and clinical evaluation. And then functional status was evaluated in several ways, including the Karnofsky Performance Scale, which is shown here. Each patient's initial and final protocol MRIs were reviewed for tumor number, type, and volume. And volume was calculated using a simplified ellipsoid volume formula, which is shown on the right side of the screen. Tumor type was determined based on imaging features, except for in the small percentage of cases where we had pathologic data to confirm tumor type. We then, for genotype determination, we created a custom PCR panel that included whole exome sequencing of the NF2 gene that we used on patient serum samples. We also included genes with disease complexes that overlap with NF2, including the most common causes of schwannomatosis, which are SMARCB1 and LZTR1. We were able to find single nucleotide variants and even low frequency variants to indicate that would indicate a mosaic disease. But this analysis did not allow us to detect large copy number variants. So a little bit about the patients in our cohort. Their age at diagnosis was a wide range from 4 months to 67 years, with a mean of 22.7 years of age. Presenting symptoms were most often related to vestibular schwannomas. A significant portion was diagnosed due to screening of affected family members. And then less commonly, patients were diagnosed due to extramedullary spine tumors or other tumors. At the time of enrollment, about 1/3 and 1/3 of patients had bilateral or unilateral non-serviceable hearing, with normal hearing at the time of enrollment on only 15% of patients. Facial nerve dysfunction at the time of enrollment was also fairly significant, with about 18% of patients having a unilateral House-Brackman score of greater than 3. Functional limitations caused by NF2 were not infrequent, although 88% of our patients were ambulatory without assistance at the time of enrollment, and over half of them had a KPS of 90 to 100. And then over the 5-year study period, decline in KPS was seen in about 30% of patients, although most patients remained stable to improved. The total tumors on imaging varied widely between patients. There were as many as 165 tumors counted in a single patient, with cranial meningiomas being the most frequent, followed by spinal schwannomas, then cranial schwannomas, spinal meningiomas, and intramedullary spine tumors. The distribution of tumor types was not uniform, with some patients demonstrating a tendency to develop many meningiomas or many schwannomas rather than many tumors overall. Another important characteristic that we looked at was the surgical burden throughout each patient's lifetime, so including before and during the study period. On average, our patients in our cohort had about one surgery every 11 years. The most common tumors resected by number were peripheral nerve schwannomas, which were often removed multiple at a time, and then followed by vestibular schwannomas and extramedullary spine tumors and cranial meningiomas. This figure just shows kind of the wide range of NF2 related surgeries that we included in our analysis. And then mutation types in our cohort, they were similar proportionally to what has been reported in the literature, with nonsense mutations being the most frequently observed. We did have previous genetic testing for about a third of our patients, which is why we were able to include large deletions in this analysis, even though we weren't able to detect that on our PCR testing. This figure shows the distribution of mutation types and location within the gene that we found in our patient cohort. The Merlin gene structure includes a firm domain on the N-terminal region, which is a domain that's highly conserved within the firm protein family, then an alpha coil region and a C-terminal region. We looked at several measures of disease severity in the context of patients' mutation types. At the bottom of the screen, I have the structure of the Merlin gene shown again with the exons corresponding to each domain. And on this graph, the location of each patient's mutation in terms of the first exon affected is plotted on the x-axis, and then the size of the dots indicates whether the mutation type is truncating or not. And then the y-axis is the total number of tumors on MRI. So the number of tumors is variable, but we observed that mutations in exon 8, 11, and 12, specifically truncating mutations at the border of the firm domain and the beginning of the alpha helix, those patients tended to have a greater number of tumors on MRI. On this slide, the tumor types are separated with schwannomas on the left and meningiomas on the right. We can see that cranial and spinal schwannomas occurred in higher numbers for truncating mutations at exon 8 versus meningiomas were associated more with truncating mutations at 11 and 12. For intramedullary spine tumors, the pattern was less pronounced, but similar to what we saw for total tumors. And then looking at total number of surgeries within the 5-year protocol period, there was a bit of an increase seen at exon 8, 11, and 12 altogether, but this difference was not significant in our analysis. So looking at several different measures of disease severity and patient characteristics with a multiple linear regression, we found that change in KPS was predicted by initial KPS, number of tumors on initial MRI, and positive family history. New tumors were predicted by the number of tumors on initial MRI and younger age, and change in tumor volume was predicted by younger age and presence of truncating mutations. Interestingly, in our cohort, the previously observed association between truncating mutations and mortality was not significant. Mortality was predicted by initial KPS, number of tumors on initial MRI, and number of surgeries prior to protocol entry. We separated out the exons 8, 11, and 12 truncating mutations. That did not have a significant effect on mortality either. So overall, our data suggests that more severe disease, at least in terms of number of tumors on imaging, may be associated with truncating mutations in the distal firm domain of the Merlin gene. And the hypothesis we formed was that the truncating mutations in this region make the protein unable to adopt a closed configuration. When Merlin is in its open configuration, it acts as a scaffold for multiple pathways involved in cell proliferation. And when it is in its closed configuration, it goes into the nucleus and removes that scaffold for cell proliferation and acts in the nucleus to reduce cell proliferation signals. So if it is unable to adopt that closed configuration, it both increases cell proliferation by acting as a scaffold and doesn't do its job within the nucleus to act as a tumor suppressor. So our thought was that truncation of the protein near the alpha helix may prevent that folding and prevent it from acting as a tumor suppressor in the nucleus, and may even allow it to continue to act as a scaffold within the cytosol for cell proliferation signals, making it sort of a oncogene. To confirm these trends and understand why they exist, we'll of course need more data and additional studies, but that was the hypothesis we formed based on our data. So in conclusion, NF2 is a systemic disease with multiple manifestations. The type and number of tumors is highly variable between patients, and the relationship between mutation type and disease severity is complex. But our hypothesis is that more severe disease may be predicated by an inability of the mutated protein product to adopt a closed configuration. Right now, the natural history study has entered a second phase that's recruiting patients at the NIH. So we're hoping to build upon those findings with these additional patients and gain a better understanding of disease. That is all I have. I'm happy to take any questions.
That was great, Emma. Thank you very much. I'll lead off. I trained at Mass General, as many of you know, and Bob Martuzza, the chair at that program, actually was one of the investigators who discovered the gene. And so he was the first in the world to have a dedicated clinic to neurofibromatosis type 2. And I still remember as a medical student when I rotated there, seeing patients with him in the clinic, newly diagnosed NF2 patients. And the counsel was, please learn to sign language, right? Because the presumption was you're going to become deaf at some point, and Braille, you're going to become blind. And many of you have seen in my practice those end stage patients who are deaf, blind, can't communicate. It's a very debilitating disease as opposed to NF1. The surgeons can see the phenotype of these tumors. You mentioned the clumping, the collisionness of the tumor. Response to therapies are very different than sporadic tumors, schwannomas, ependymomas, and meningiomas. In a family with the same germline, something that I've certainly noticed, and many of you have too, you may have dozens and dozens of tumors in a 5-year-old or in a 30-year-old. Why is there always one or two leading the growth curve, right? The presumption is all the tumors, meningiomas, schwannomas, and ependymomas in that one patient have the same germline variant, right?
Mm-hmm.
But why is there always one or two of those tumors that lead the growth curve? And those are the tumors that we're exhausting our time operating on, giving radiation. We have no systemic therapies. Any thoughts about that gives that variability?
I think what we've seen in my part of the lab was and is still, I think, dedicated right now to working on single nucleotide and single cell DNA and RNA testing of the tumors resected from these patients, and they found different patterns of mutations in more aggressive and less aggressive tumors, but still are working on understanding which mutations kind of kick off that more aggressive phenotype in certain tumors.
Thank you. Any other questions from our team? Jake?
No, I think it's a very nice presentation, and clearly this is going to be solved by genetic manipulation rather than by, surgery is wonderful, but, and then we all love to operate, but it's a stopgap measure in the natural history of these patients. So we need to, at the moment, of course, our philosophy remains that we operate on symptomatic cases, and sometimes it creates real clinical and ethical dilemmas as to, how, when to intervene and how much to remove, and is radiation therapy appropriate, and all these questions that we grapple with in these folks. And Manny obviously has an NF2 clinic, and he sees a lot of these folks at UWMC. And whenever any of us see these folks, it's a real problem for us as well as the clinicians as well as the patients.